Hi, I'm going to be discussing with you your upcoming surgery replacement of internal pulse generator. Uh, the internal pulse generator is the pacemaker-like device in your chest that provides the power and the stimulation settings for your deep brain stimulation therapy. I'll refer to this as an IPG. On the day of your visit, we'll review options, including rechargeable and non-rechargeable devices, and which device you have in place, Medtronic, Abbott, or Boston Scientific, and what your neurologist or you prefer or recommend. This is implicitly part of DBS therapy. So when you first underwent DBS, presumably you were aware that at some point the pacemaker needs to be replaced, and that's what you're being referred for. I typically perform these procedures on Tuesdays at an ambulatory surgery center, also known as an outpatient surgery center. The one I perform these at, I am a co-owner in, and it's on the first floor of the same building that the Muhammad Ali Center is. So those of you who go to the Muhammad Ali Center for your care, on the third floor, the first floor is the surgery center. If you prefer to have this done in the acute care setting, the hospital, you can request that. Also, if your medical risks preclude outpatient surgery as an option, we may schedule your operation at the hospital as well. And that the hospital has the options of ICU care, overnight stays, and we also have typically use general anesthesia there, and we have residents who help participate with the operation. Typically for a single incision, the operation takes about 10 to 20 minutes. And before you come to surgery, it's important to be aware that to mitigate risk, the night before, you should bathe and shower using HIPAA-cleanse antimicrobial soap. So you can pick this up at Walgreens. It's your responsibility to pick this up and to comply with this step, which is cleaning this chin to toe the night before surgery and the morning of surgery. And that's to decrease the risk of an infection. Don't use any other antibacterial soap. Don't use other skin products like lotions or powders. And again, the night before and the morning of, wash and HIPAA-cleanse. Do not eat anything the morning of your surgery. So nothing to eat after midnight the night before. If you show up to surgery and you just had a breakfast burrito, we're going to cancel your operation. So it's important to be aware that because you're going to be sedated, either with general anesthesia or IV sedation, not to eat anything after midnight the night before. So nothing to eat, and this includes water, alcohol, gum, or mints. You can have your medications with a sip of water. So actually, you're supposed to take your medications the morning of, and you can have a sip of water to swallow your medications. Before surgery, it's also incumbent upon you to make sure that you've stopped all aspirin products, Celebrex, Plavix, Coumadin, or other blood thinners, typically about 10 days before surgery, or unless otherwise directed by your prescribing doctor or by a neurosurgeon. For example, aspirin and Plavix actually take about 2 weeks to fully get out of your system. Other medications, I believe, like Eliquis, may take like 3 days to get out. And the idea here, this is not a high-risk operation, but we don't want we need your blood to clot normally in order to do this surgery safely. So just be aware that those medications can influence bleeding, and we want to control that for surgery preoperatively. Also, stop taking any non-steroidal anti-inflammatory medications. That's basically like Advil, Aleve, ibuprofen, naproxen. Stop this for about 10 days before surgery. You are allowed to take Tylenol because Tylenol does not thin your blood. Parkinson's patients, you're expected to take your medications with a sip of water the morning of surgery. So continue taking your medications. And also, I recommend that you bring your Parkinson's meds with you so that you can take your next dose on time after the surgery is completed. An important part of every operation is informed consent. So you sign a permit allowing me to perform the operation, and implied in your signature is that you understand what the risks, the benefits, the alternatives, and indications for surgery are. So I'm going to be going through some of those risks now. Some of the pertinent risks: damage to the wires, infection, hematoma, which means blood, and that creates a problem and where I did the operation, wound healing, also the risks of anesthesia. So hardware damage, this is an example of an internal pulse generator, and it's a little bit blurry because this is the one I could find that has the wires included. right where the wires exit the generator, I plug these wires into the generator, so the generator is separate from these wires. And right at the point of entry, there's a point of vulnerability, and actually state in my consents that the risk to the Medtronic 37089 extension, risk to injury exists. My opinion is that it's overly vulnerable to normal surgical manipulation, and that damage can result in possible loss of therapeutic benefit. All the generators, there's a risk of breakage of these leads. It's not that I can't actually see the break, but when we run current through your system, we can measure the circuits, the resistance of the circuit, and that's where we can detect whether there's a break in the system. So it's not something that I can see at the time of surgery, but something I can measure. And I do that measurement as soon as I plug everything in. I measure to see if all the circuits are running appropriately. Typically, we'll have up to 16 different circuits. And if one of those are faulty, it may mean that we have an issue. So these are non-visible fractures that may occur at the sites of vulnerability. Rarely, we might actually have a visible fracture. If there's damage to that extension, if there's something that suggests there may be damage, it's important that you're aware. My usual practice is that I do not fix that at the time of surgery. Fixing it would consist of opening up on your head, and that wire that goes down your neck, I would have to replace it, remove it, and manipulate the wires that actually go in your brain in order to replace the wire that goes down your neck. So my practice is that I don't actually fix this issue at the time of surgery. There's other reasons for that. One, it's a separate operation. We have to undrape, re-prep, and it adds additional risk. Also, I've seen these circuit issues resolve on their own, and so I don't want to chase a false alarm by over-interpreting a finding that we see at the time of surgery. So there's always the possibility that this circuit abnormality resolves on its own. Also, even if it persists, typically so far as therapeutic benefit, neurologists are typically able to program around the lost contact. Again, there's about 8 contacts per side. Typically, the older systems have 4 contacts per side. And typically, if one of them are out, the neurologist can use the other ones. There's some redundancy in the system to maintain therapeutic benefit. So that's another reason why I don't chase this down and correct it at the time of surgery. And then a third one to be aware of is that if this abnormality does persist, even if we're able to program around it or maintain therapeutic benefit, you may not be able to get an MRI because the MRI compatibility of the system depends upon all the circuits functioning. So if the problem persists, that results in loss of therapeutic benefit, then if there's hardware damage, we will return to surgery. We'll schedule a new operation, and we'll go and do the surgery separately on a different day, weeks later. So we can always go back and do the surgery, but it's important that you're aware that I don't do that surgery at the same time as the replacement because of these various factors. This risk is about 1%. I may see it one time a year out of over 100 patients, so maybe even less than 1%, but it doesn't matter how small it is. It's important that you're aware this could happen to you, and it's part of what you acknowledge with informed consent. Infection. So here's some gross pictures of batteries that are eroding through the skin at the side of the chest. We have bugs in all of our skin. All of us have bugs in our skin that if we cut ourselves can cause an infection. That's why when we get a cut, we wash our hands, right? We wash the wound. So they're there, and it's just part of, it's normal. But when we do hardware, the way that bugs interact with hardware is such that we can't just treat it with antibiotics. It can really stick to the hardware, and these infections typically don't appear for like a week or more after the operation. So there's a risk of an infection with every operation. In this case, because it's hardware, it's important that you're aware that the definitive treatment of a hardware infection and deep brain stimulation is to remove the entire system. And that could include the brain leads, the wires that go in the brain. So that's a risk. Often we'll try to get away with just removing the battery and the wires that go down the neck and hope that the infection was just localized to the chest. But it's important that you're aware that that's a salvage procedure, and we may end up back in surgery having to take out the wires from the brain. So that's an intrinsic risk of this operation. It's rare that this happens, maybe once a year. I'm taking out part or all of the system for infection. But again, that you're aware that this could happen to you, and that's what we acknowledge with the consent. Having a blood clot, that's kind of, creating an issue that we have to drain it, or having the wound just not healing. Those are other risks that could complicate the operation and result in things like an infection or additional surgery. I do these operations with an anesthesiologist present at St. Joseph's Outpatient Surgery Center, the ASC. That's typically done with IV sedation, though also there are anesthesiologists who prefer to use general in that facility. So a lot of that is anesthesiologist preference and something you can discuss with the anesthesiologist when you meet them on the day of surgery. At St. Joseph's Hospital Medical Center, that's the hospital, that's an acute care facility, and typically the anesthesiologists there use general anesthesia. That can be safe, and even when I've seen patients who've been recommended, if possible, for no anesthesia, patients tend to do well with this because the general anesthesia is typically light. But if you have medical problems that may increase your risk for anesthesia, let us know. You will be signing a consent for anesthesia separately, and implied in that consent is that you're agreeing to the type of anesthesia that the anesthesiologist is recommending and plans to use. If you disagree, discuss that with the anesthesiologist, and you always have the option to cancel your operation if you don't agree with the plan. Be aware with this operation, just in general, catastrophic outcomes are rare, but we always include these in our consents: death, coma, stroke, paralysis. These are extremely unlikely, something I in no way am anticipating, but the risks of any operation are never 0%, so these are included in the consent. Post-operatively, these replacements are outpatient surgery, so you will be discharged the same day as surgery. For pain, it's important that you're aware I do not prescribe narcotics for this operation. I will not prescribe you a prescription. I will not provide you with a prescription for pain medicine. I don't write any prescriptions for this operation. And maybe once a year, I'll have a patient who expresses some dissatisfaction that they didn't have pain medications afterwards, but only one. So it's not my practice to prescribe you a narcotic for the pain. Tylenol is recommended for post-op pain. It's okay if you use a non-steroidal inflammatory like Advil, Aleve, ibuprofen, naproxen. I'm okay with you using that after the operation. Also using clean ice packs, 20 minutes on, 20 minutes off. That can help with the pain. In general, if you can wait 3 days before starting the NSAIDs, that's better. But if Tylenol and ice don't work for the pain, I'm okay with you using some ibuprofen or something like that. You'll typically have a dressing. I typically close these with staples, and that'll be covered with a dressing. I want you to leave that dressing dry for 3 nights. So say I typically do these on Tuesdays. You can remove the dressing on Friday, but leave it in place and dry until Friday. Once you take the dressing off, you can leave it off. You want to leave that wound clean and dry, but you can shower. Don't soak it. Try to avoid immersing it in like a bathtub, a pool for about 6 weeks. And I recommend using Aquaphor or bacitracin. These are both over-the-counter ointments that you can get at Walgreens, and you can apply them lightly to your chest twice a day for about 7 days, and that helps with the wound healing. So that's a summary of the operation, including what to expect before and after, as well as intrinsic risks. And we'll have you acknowledge that you watched that. I think there should be a click with this platform, and I'll see you soon. Thanks.